Welcome to part 2 of 2 presentations on the thoracolumbar spine. It's a continuation of thoracolumbar spine part 1. We start with vertical compression fractures and then look at specific diseases like osteoporosis, multiple myeloma, metastases, Paget disease, ankylosing spondylitis, and then take a look at the spons.
Vertebral compression fractures are really common. The 3 most common causes of vertebral compression fractures are osteoporosis, which is a metabolic complication, and the vertebral fracture is the most common type of osteoporotic fracture. So you've got an annual incidence of about 1.4 million in the EU. Then METS is the second most common reason. And vertebral compression fractures are the most common skeletal complication, and the big 3 are breast, lung and prostate primary. And then finally is trauma. Osteoporotic vertebral compression fractures are more common over the age of 50. And then they increase with each succeeding decade. They're much more common in women than they are with men, and that's basically because in postmenopausal women what happens is they've got a higher risk of osteoporotic compression as their vertebral trabecular bone density decreases. So the biggest area is most likely the mid-thoracic spine and the thoracolumbar junction. So you get this classic kyphotic deformity of the patient, which is sometimes nicknamed the Dowder's hump. So with osteoporosis, you get the selective deficiency or the removal of the horizontal trabeculae. And then this is associated with microfractures of the vertically orientated trabeculae beneath the superior and inferior vertebral end plates. So if you compare the normal trabeculae on the left, you can see that there's a much thicker cortex in comparison to the right. You can see that the bone is much more dense, and then on the right hand side you can see with the loss of the trabecular pattern, it means that it's much less dense in appearance, so it's very osteopenic. We describe it as osteopenic with radiology, not osteoporosis, because osteoporosis is a clinical diagnosis. And when you get osteoporotic fractures, they are actually a true fracture, because if you look under a microscope, you will actually see that there is the woven bone actually forms like trabecular microfractures, so therefore this is a true fracture. The biggest problem with an osteoporotic fracture is being able to differentiate acute from chronic, because quite often these appearances have been around for a very long time. So that's the biggest challenge. If you look on the left, we can see a real depression of the superior vertebral end plate caused by an osteoporotic compression fracture. And you've got different types of compression fractures, and we'll look at that now. So the one that we're very familiar with is the wedge compression fracture, where you can get loss of the anterior vertebral body. And remember, we describe it as mild, moderate, severe, rather than grade 1, grade 2, grade 3, grade 4. I think that's easier to recognise. We can see that this is very much mild, this is moderate, and this is severe. Then you've got 2 other types of osteoporotic vertebral compression fractures. In the middle, we have a biconcave compression fracture, where you start to get compression of both vertebral end plates, and you end up with this real squished in of the middle portion of the vertebral end plates, and the nickname for this is codfish vertebra. Now be careful, you can get a normal variant of a slightly biconcave fracture, concave appearance, and you'll see this in younger individuals. Now that's not to say that those younger individuals will at some point become older, but it's about recognising that if you get a slight biconcavity in a young person, it doesn't necessarily mean that this patient has an abnormal vertebral column. And then of course you've got the crush fracture, where it's a complete reduction in vertebral height the whole way across. So you've got mild crush, and then moderate crush, and then severe crush fracture. And you can see that you tend to get these little fractures in the middle portion in comparison to the biconcave, where you get the fractures through the vertebral end plates in the anterior portion. So here we have a classic patient with severe osteopenia, with multiple wedge compression fractures of the thoracic spine. And you can see they've got a really severe kyphosis, otherwise known as a Dowger's hump. And if you look down in the lumbar spine here, we've got a nice, well, not nice, but we've got a biconcave fracture. These vertebral bodies are relatively well preserved. Then you've got slight wedging, and then you've got real wedging around the mid-thoracic spine. This vertebra is not that bad. And then again, real wedging of the upper thoracic spine. So we've got multiple compression fractures. So there are two arguments really. An isolated vertebral compression fracture should sometimes be viewed with suspicion, because it may well be due to another pathology, multiple myeloma. Generally, what you have with osteoporotic fractures, they tend to be multiple contiguous vertebra, whereas if it's to do with an aggressive process such as a MET or multiple myeloma, they tend to be either a single vertebra or multiple non-contiguous vertebrae. So that's one way of being able to differentiate an osteoporotic fracture from maybe something more sinister. So what have we got in osteoporotic fracture? Where thoracolumbar spine, how multiple wedge compression with loss of anterior vertebral body height. So multiple myeloma is the most common primary bone cancer. It involves the red bone marrow, and because of that it has a predilection for the flat bones and the vertebral column. So you'll see it in the skull, you'll commonly see it in the pelvis, the vertebral column, and then around the proximal portions of the femora before it then extends along the long bones. So the classic appearance of multiple myeloma are multiple punched out lytic lesions, and within the vertebral column you're looking at really severe osteopenia. And interestingly, with multiple myeloma, you have the rule of thumb is that you have a sparing of the pedicles. So when you look at your patient on the AP view, you should still be able to visualise the pedicles, which will help you towards your diagnosis of multiple myeloma. So what is it, multiple myeloma? Where skull, vault and vertebral column, how multiple punched out lytic lesions. Now, osseous metastases, like multiple myeloma, has a predilection for the flat bones and for the axial skeleton. So basically your skull vault, your spinal column, your pelvis, and as I say, your proximal femur and so on. Osseous metastases, they can either be lytic, and classically, so lytic lesions, you're looking at lung and breast can be lytic, as can renal. And then you have sclerotic, so our really classic sclerotic metastases is from prostate. But you can have sclerotic mets from breast, and that's usually after they've started to have treatment. And then of course, just to make things really interesting, you can have mixed, so you can have both lytic and sclerotic appearances. So this is a really young child, unfortunately. This is an 8-year-old with a neuroblastoma, and we can quite clearly see that we've got really diffusely abnormal sclerotic mets throughout the vertebral vertebrae. So if you look at L3, L3 has been completely preserved. So this is a very normal vertebrae in comparison to all this abnormal sclerotic mets everywhere. Now, in contrast to multiple myeloma, mets goes for the pedicles. That's where it likes to go first. It sort of gobbles away at it. So then what happens is you're looking for your absent pedicle signs. We'll look at that next. So what is it? It's osseous metastases, where T10, T11, L2, L4, L5. How sclerotic. And so this is why I like you to check your pedicles, not only because I want you to check to see if you have widening of the interpedicular distance, which will indicate that you've got an abnormality to the posterior column because you've got widening of the pedal spaces. But I want you to check your pedicles to see if you have an absent pedicle. And an absent pedicle is highly suspicious, particularly for metastases. Now you can have a normal variant where you have an absent pedicle, but the most important thing is that you exclude a met before you start saying it's a normal variant. So here we go. Here's T11, so we've got pedicles here, 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 and here, and here. And then suddenly in L2, you've completely lost that pedicle. Some people like to think of the vertebrae as an owl. So your pedicles are the eyes, and the spinous process is the beak, and the vertebral body is the little owl itself. So people use this winking owl to help them, remind them that they have to check for pedicles. So what is it? It's an osseous metastase, where the left L2 pedicle and how absent pedicle sign. Paget's disease, classically seen in Caucasians of British nationality or Australian or New Zealand, so basically the Antipodeans, the white Antipodeans. And so what you get with Paget's disease is you get this enlarging of the bone with this really coarse and trabecular pattern and a kind of picture framing. So if you look at the relatively normal vertebral body above and below, you can see that the cortex is normal in comparison to the thickened cortex of the Paget's disease, and it looks cool. It's described as picture framing, and you can see quite clearly this really very sclerotic, coarsened trabecular pattern. So Paget's is enlargement of the bone, picture framing in the vertebrae with coarsened trabeculae, and you may even get a sclerotic pedicle. But we can see, if we compare the two vertebrae above and below, we can see that there's enlargement of the vertebra, but there's no evidence of a fracture to it. You've got pretty marked osteophytes as well, these big bridging osteophytes, so that's pretty unpleasant looking. Just have a quick look, because we can see very slight spondylolisthesis. So what's this say? There's 12, so 1, 2, 3, 4. So we can see that there is a mild spondylolisthesis of L4 to L5, and then that's all in alignment. So important to check, because you can get these degenerative spondylolisthesis and retrolitheses. So what is it? It's Paget's disease, where L3, how enlarged picture frame with coarsened trabeculae. Ankylosing spondylitis or Murray-Strumfeld disease. This is a seronegative spondyloarthropathy. Classically, it sort of appears in the 3rd decade, although some unfortunate people it starts to present in the 2nd decade. It has a predilection for males 3 to 1, and as you can tell from the name, ankylosing meaning fusion, and spondylitis, so you've got inflammation of the spine, so spondy is pertinent to the spine. And this is a real classic appearance, is what's known as bamboo spine, as you see the vertebra fuses in all columns. And these are syndesmophytes as opposed to osteophytes, and these are vertically orientated ossification of the sharp piece fibres, and you get fusion in all 3 columns. This is means that the patient is rigid, and they're a high risk of a pathological fracture. Their fractures are sometimes called a carrot stick fracture, so it just takes a little bit of trauma, and it literally causes the spine to shatter. And the big problem with the ankylosing spondylitis is that if you have a sustained fracture, because the spine has fused, your hematoma from your fracture has nowhere to escape. So what happens is that you get multiple levels of occlusion to the spinal cord by the hematoma tracking down the canal, because it can't escape out. Classically, what you're looking for initially are fusions of the SIJs. So when you're looking at your lumbar spine, always make sure that you look at your SIJs. Are they fused or are they visible? You can get what's referred to as the dagger sign, so that becomes calcification of the interspinous ligament, and that's called the dagger sign. So that's another indication of ankylosing spondylitis. So what is it? It's ankylosing spondylitis, where lumbar, well, to be honest, it'll be in the whole spine, but how? Syndesmophotic ankylosis, i.e. bamboo spine. I'm just going to briefly mention the spons. So we've got spondylosis, spondylolysis, and spondylolisthesis. So spons is obviously pertinent to the spine. So spondylosis, this is basically degenerative changes of the spine. You're going to cover this more when you do your arthritides, but classically with spondylosis, you're looking at osteophyte formation, and that tends to occur at the anterior vertebral bodies and the posterior vertebral bodies, just on the corners where you get these little spurs forming. You get intervertebral disc space narrowing, and you get sclerosis of the vertebral end plates. You can also get facet joint arthrosis, which is slightly different. So facet joint arthrosis refers specifically to degenerative changes in the facet joints. So again, you can get joint space narrowing and sclerosis. So let's look at the other two spons in a little bit more detail. So spondylolysis is a break or defect in the pons articularis. The really important bit is there's no displacement. The current school of thought is that they're basically a stress fracture. So you classically get them with cyclists, gymnasts, and weightlifters. And like all stress fractures, generally speaking, you don't see them radiographically when they first occur. So they only start to become radiographically apparent after a few weeks. Now you may sustain them from acute trauma, or you may get them with an insufficiency fracture. So that's essentially the same as a stress fracture, except an insufficiency fracture is when it's at its normal load going through abnormal bone, which is basically osteoporosis. So let's have a quick look at this patient. We'll come down our anterior longitudinal line, and we can see that that's all in alignment. Now let's go along our posterior line. So we go along the posterior cortex of the sacrum, go along the posterior cortex of the vertebral bodies. Just out of interest, look, this beautiful curvature of the posterior vertebral cortex. That's a really good example there for you to be able to visualize that kind of natural curvature there, which you need to look for in the context of trauma, because you can get straightening or even reversal of that gentle curvature, indicating that the fracture has started to retropulse within to the spinal canal. Now let's come down, we'll have a quick look through our pedicles, and we'll come down our facets, and then we're looking at the pons articularis here. So here's our pedicles, go the facets and the pons articularis, and along here, and then we can see quite clearly we have a massive break in the pons articularis of L5S1. But as we said, the alignment is completely preserved, so therefore this is a spondylolysis. We used to do oblique views to look for the fracture through the pons articularis. We don't do that now, but I'm going to let you quickly label this because I think it helps you to kind of sort of cement in your mind how the vertebral bodies are and what you're looking at for the pars articularis. So a spondylolisthesis, as we've discussed with our cervical spine, so this is the forward slip of one vertebra in relation to the inferior vertebral level. Now in this case, this patient here has got a marked pars defect. So because there's a fracture through here, this means that our vertebra has become unstable and it's slipped forward. So similar to grading vertebral body wedge fractures, you can grade spondylolisthesis grade 1, grade 2, grade 3, grade 4, with grade 1 being up to about 25%, grade 2 up to 50%, grade 3 is up to 75%, and grade 4 is when it actually slips over the end completely. However, I think people find it quite difficult to grade it, so you could use mild, moderate, severe. So in this case, this is a mild slip of L4 onto L5. And if you look carefully, you can see there's actually a nerve pars defect in L5S1. But anyway, L5S1 is completely in alignment, so therefore this is just a spondylolysis. So there is a mild spondylolisthesis of L4 onto L5, and there's a spondylolysis of L5S1 pars articularis. So what is it? It's a spondylolysis and a spondylolisthesis, where L4, 5 and L5S1 spondylolysis only. How mild. Just as a little aside, Lance Armstrong is a famous or infamous cyclist who had a spondylolysis with spondylolisthesis, and he had to have surgery to fix his vertebra together. And remember, we briefly talked about it in the cervical spine. It's perfectly possible as we get older and our ligaments become more lax, so our anterior longitudinal ligament and our posterior longitudinal ligament becomes saggy, to get a degenerative spondylolisthesis or a degenerative retrolisthesis. But what you'll be looking for is evidence of spondylosis to accompany those changes.